information, or did you make that information? Did you opt in so that that information can be shared and taken and so forth? And I think that's a piece of this that will actually help drive that going forward.
One of the three questions we had hoped to answer today was on efficacy as kind of the final point. I know it came up during our keynote this morning that maybe there's not yet enough efficacy studies out there for certain solutions. So I was wondering, Anand, if you had a reaction to that. Do you think we need to do more studies, and what kind? And also, just if you give us an idea, for those that we have done, to what degree can we extrapolate that, okay, SMS works for reminding medication appointments? I mean, a lot of these things, at least from my opinion, like, it's one solution to the next. They all have their own nuances. How can we make broad stroke conclusions from them?
We were joking outside before we started. Why is it we send a man to the moon once and everybody believes it, but we have to do 100 million clinical trials for the same bloody thing? Oh, okay, I finally believe you. Okay, that aside, in diabetes, so we have the 2-point A1C reduction in the first trial. August this last year, our principal investigator from University of Maryland presented, so I'm under embargo, which is why I'm being very formal, presented our preliminary data that showed a 1.91 point A1C reduction in a large clinical trial, multi-year study. These are unheard of results in the pharmaceutical community of that kind of change. There's lipids benefits they're going to be publishing, blood pressure benefits, body mass index benefits. If I look at the adherence side, AstraZeneca, My Measures of Success, My Measures for Success program, they measured refills at 1 week, 2 weeks, 3 weeks, 4 weeks. So they measured persistence, compliance. The numbers went up by 70 to 80%. They actually measured conversions. So they did a small pilot where they gave a patient the option to switch to their drug who was on another drug. And they got either you just switch or you get WellDoc and the switch. And they were 27 times more likely to switch. Now, from a prescriber's perspective, doctors who got that 1 page of analysis every 3 months or whenever they chose to get it were 5 times more likely to make a medication change or titrate a medication than the doctors in the control group. So we saw data that showed physician adoption and movement on the clinical prescribing side. We saw consumers, how they increased their adherence. We saw outcomes. I think we need to see more of this. This is my call to the rest of the mobile health community is show that these things work clinically. Show that they're integrable into the life of a doctor, into the life of a patient. Show accessibility by working through plethora of, let them use the device that they want to use. Let them access it how they want to do it. Then we'll all win. That's how we're going to change this problem.
There's also a structural impediment here that we're going to need to grapple with at the FDA. On the food side, there are concepts where FDA can recognize what is generally known. It's called generally recognized as safe. On the drug side, there's a concept generally recognized as safe and effective. It keeps you from having to reprove the same things over and over again because there's this general recognition. 30 years ago, when they wanted to start selling Cheerios and saying Cheerios would help lower your cholesterol, at the time, the scientific principles behind it were fairly well accepted, but there was no mechanism at FDA to deal with that. So FDA was almost forced to treat that as a drug, treat Cheerios as a drug because of a claim that it would reduce your cholesterol. What we really need on the device side is that same sort of general recognition. We need, and there isn't a statutory provision for it right now, but we need a mechanism by which FDA can say, okay, you don't need to reprove everything that's well accepted. Just prove that incremental new part associated that's unique to your technology. That's a missing piece here. Do you have a question?
Oh, great. Question from the audience? Do we need a mic for the questions, or are we good?
We're ready.
Oh, great. Thanks, Joe.
Hi, my name is Barry Lotion with Connexus. My question is really for you, the attorney representing the medical device folks with the FDA. I've heard through the grapevine over the last year that the FDA is really trying to reorganize itself because one of the problems is in the backlog is that they have such few staff working on these FDA approvals that they just, it's overwhelming for them. And from an agency perspective, I guess I know that there's been a lot of discussion with the new FDA commissioner and so forth coming in. I heard her speak last year, and she said she's going to be focusing on this. Well, it's been a year, And I just wanted to know if you know of any major changes or organizational increases in the number of FTEs that are going to be working on these particular approval committees and so forth.
Well, the FDA actually, when it comes to the approval function at the agency, has a mechanism to generate funds. It's called a user fee. And every application you have to pay, if it's for the low-risk devices, you have to pay a little over $5,000. If it's for the higher-risk ones, it's north of $250,000. But you have to pay in order to have your product reviewed. So it's a self-funding mechanism. The more work, the more revenue comes in, and they can use that revenue then to hire reviewers. That said, you know, the pay scales and so forth at the agency have made it difficult for them to compete with industry to get the top talent. And that has not gone away. That remains a problem. And FDA complains bitterly. We hire somebody, they work here for 2 years, they just learn the system, and industry hires them away because they want people who know the roadmap. They want people to be able to lead them through it. So it is a chronic problem at the agency, and they've made some progress, I would say, but it's never ending. They keep losing people almost as fast as they add them.
Time for one more question. Anyone? Or you just got everything answered? Can I have you yell? Because I'm not jumping.
For those who couldn't hear, the question is really what role does MDDS play in our meeting on Monday? MDDS is a proposed rule that was proposed just about 2 years ago, actually coming up on 3 years because it was 2008. So it's been sitting there. They proposed it. It's a way to deregulate passive databases that have medical purposes. It has to be a passive database. It can't in any way control devices that might be connected to it. FDA had proposed that those sorts of databases would be in Class 1, which means they're regulated by FDA, but you don't have to get approval for them. So that's, in a way, reducing a roadblock. They got a lot of negative comments on that proposal, and they've been struggling for 3 years to figure out what to do about that proposal. We're watching it. The FDA is not at liberty to talk about it, though, because as a proposed rule, for any number of reasons, investors and so forth, it would be inside information if they shared with somebody, you know, exactly when it was coming out. But they've told generally the public that they're working on it, and I've heard a number of people say that they hope it'll be published in the first quarter. But it won't be an express topic on Monday because there's this really prohibition against discussing it. A number of things that we're proposing will, by implication, affect that rule. We won't characterize it as a comment on the MDDS, but a lot of what we're talking about may well affect their thinking on the MDDS. Mm-hmm.
Wow. This was really, really informative, really interesting, and I want to thank all of you for taking the time to be with us today.